You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 6th, 2023. This week, coated or uncoated aspirin, a new trial in coronary artery disease, conflict of interest, first episode of AFib in the hospital, and changing hypertension scoring affecting the CHADSVASC score. Now, let's first talk about aspirin. I've always felt that enteric-coated aspirin was either equivalent or better than regular aspirin. Now, I admit, I hadn't done an extensive literature review. Let's remember the adaptable trial. May 2021, New England Journal. This was a huge pragmatic trial of 15,000 patients with established atherosclerotic heart disease, and they were randomized to aspirin 81 milligrams or aspirin 325 milligrams. Adaptable found no significant differences in either the MACE efficacy endpoint or major bleeding. Notable with adaptable was its pragmatic nature. Patients, once randomized to dose, bought the aspirin on their own. Some bought enteric-coated aspirin, some bought uncoated aspirin. Now, JAMA Cardiology has published a post-hoc secondary analysis of that trial looking to explore associations between efficacy, which is the MACE endpoint, and safety, bleeding outcomes, depending on the reported formulation of aspirin. The first author, Dr. Amber Sleem. About 70% of patients reported the type of aspirin, coated or uncoated, that they took. Now, picture sort of the trial ladder diagram. First, there were two groups based on dose. This was 81 or 325. Then, within each of these doses, there were those who took coated or uncoated aspirin. Most actually took the enteric-coated aspirin. The investigators then compared outcomes based on self-reported type of aspirin. They plotted the Kaplan-Meier event curves and found no significant differences in either MACE or bleeding events. Now, one of the challenges, especially for bleeding events, was that in this trial there were a low number of events, and this led to wide confidence intervals. For instance, in the group that took enteric-coated aspirin, the adjusted hazard ratio was 0.82 for bleeding. That's an 18% reduction. But the confidence intervals were wide, ranging from 0.49 to 1.37. So the authors write, after making their conclusion that there was no difference, they write this phrase, quote, although a reduction in bleeding with enteric-coated aspirin cannot be excluded, more research is needed to confirm whether enteric-coated aspirin formulations or newer formulations will improve outcomes in this population. My comments are that I like this kind of work. Yes, even though the data comes from an RCT, it is still observational, right? Because the choice to take coated or non-coated aspirin was not random. It's still worth looking for signals within RCTs. The author's limitation paragraph is also laudable. Take a look at that. That's how limitation paragraphs should be written. They list all the issues with potential confounding. Now, given the low event rates, even in this secondary prevention cohort, I don't see how it could ever be sorted out whether aspirin coating makes much of a difference. The size of that RCT would have to be so massive. To me, it seems there are many other important things to study with Pecori's money. All right. Next topic, recharge. Speaking of Pecori, the Patient-Centered Outcomes Research Institute, they have just funded a massive new trial called RECHARGE, or Revascularization Choices Among Underrepresented Groups Evaluation. That was the name of the trial. Now, this RECHARGE trial has two huge, unique twists. RECHARGE will pit PCI versus CABG in patients with suitable anatomy. The twists are that it will recruit only women in one arm and patients from minority groups in the other. There'll be 2 parallel trials, one with women and the other with the minorities of any sex. And the other twist of Recharge is the endpoint choice. This is overall death, that's one, and the other in the composite is non-disease specific quality of life measured by the SF-12 questionnaire. Gosh, this is a super interesting topic. It really makes you think about trials and endpoint choices. On the one hand, on the surface, this is a great effort to learn about 2 groups of patients that are underrepresented in coronary trials, women and minority patients. One of the co-primary investigators, Professor Mario Gaudino, has said that women should not be considered smaller men. He means, I think, that there is great uncertainty translating data from trials done mostly in men to women. I mean, the main thing to think about in this effort are the endpoints. Endpoints are becoming really tricky. They can affect so many things. Gaudino and co-PI of Recharge, Dr. Greg Stone, have proposed in a May JACC piece titled Reconsidering the Direction of Coronary Revascularization Trials, and I'll link to that paper, that trialists should consider moving away from the MACE endpoint and moving toward quality of life endpoints. I agree that MACE endpoints are harder now, especially since MI has been so difficult to define. But perhaps this is not the time to change. MACE may actually be a really important thing to study in these special patient groups. If nothing else, but a comparison to previous trials. I mean, how will we be able to compare this new Recharge trial with data from the older trials without a MACE endpoint? Another issue with the trial is the choice to use quality of life measures so soon after the procedure. Well, clearly, CABG versus PCI trials could never be blinded, and quality of life early is going to always favor PCI. The benefits of CABG over PCI in previous trials like FAME-3, for instance, have taken time. Right now, they plan to use quality of life at 1, 3, 6, 12, 24, and 36 months. To me, why would you even do quality of life at 1 and 3 months? It will favor PCI. Why not do it, for instance, at 3, 4, and 5 years? A more specific criticism, and I would have not known about this had I not been assigned a lecture on endpoints, is the choice to do an SF-12 survey instead of the more comprehensive SF-36, which is more validated. I suspect, but don't know, the choice to use a simpler measure just relates to trial efficiency. I'm not sure they wouldn't want to gather more and richer information in this novel undertaking with these special patients. Criticism aside, though, this seems like an extremely worthy and ambitious project. I also hope, since it's funded by PCORI, that full transparency will be available, and maybe they'll break ground, too, on leading the way toward a new culture of independent validation and open data and peer review. Okay, next topic. Speaking of transparency and trust, the next topic will deal with conflict of interest of public commenters on NCD draft statements. JAMA itself has published a very interesting research letter. The title is Financial Conflicts of Interest in Public Comments on Medicare National Coverage Determinations of Medical Devices. The first author of this research letter, Dr. Angela Liu, who at the time was a third-year medical student at UCSF. She teamed up with senior doctors there, including Rita Redberg and Sanket Dhruva, to assess the comments made when CMS publishes draft statements for upcoming national coverage decisions or national coverage determinations, or short form NCDs. Now, the teaser, before I say more, is that they wondered whether or not people who commented would be A, proponents of the new procedure, and B, would they disclose any of their financial ties. First, a little background. CMS sometimes decides that invasive, costly procedures require strict coverage criteria, like, say, for instance, the ICD for sudden death prevention or pacemakers for bradycardia have NCDs. And you cannot break these NCDs. They're very strict. CMS first does an extensive literature review, then they published an NCD draft, then they allow comments. Now, in this specific case, the authors looked at 681 comments on 4 proposals for pulmonary embolectomy, transcatheter mitral valve repair, artificial hearts, and related devices, including ventricular assist devices and transcatheter aortic valve replacements. Okay, that was part 1 of the study, was to look at the comments. Part 2 was then using the open payments database to establish payments received by the commenters, mostly physicians. Now, not all were individual doctors. About a third of the comments came from organizations, and it was a little harder to sort out that funding. They had to go to annual statements and websites and the like to find funding results. Now, the results. First, the commenters were largely positive. Get this, quote, among the 3 NCDs in which CMS was considering expanding coverage, 424 of 428 comments, 99%, supported coverage expansion. Their second main finding, of the 440 physician commenters, including individual physicians and those from groups of multiple physicians identified on open payments, 76% had received at least one financial payment from device manufacturers potentially affected by the NCD. Pause. 0.3% of whom disclosed the financial conflict of interest. The physician's median total value of general payments from the open data website was $5,000. Of the 53 unique teaching hospitals, 83% received at least one general payment from device manufacturers, but none disclosed that financial conflict of interest. And of the 66 organizations that submitted public comments, 79% had financial conflict of interest, and one of which was disclosed. So my comments. I think these are really important observations. First is that nearly all commenters were proponents of the device or procedures. They found no medical conservatives saying we should be careful about expanding coverage. Second observation is that nearly none of the commenters thought to voluntarily cite their conflicts. When I tweeted this paper out, many responded by saying, hey, John, there was no place on that form to list conflicts. The authors of this paper argue, based on their findings, that there should be a place to disclose conflicts. But the point I want to make is that nearly none of the 680 commenters felt like conflict of interest should be stated along with their comments. It's akin, I think, to not having a disclosure slide during a PowerPoint talk. I don't think I've ever given a PowerPoint talk without having a disclosure slide. And I'm not saying that anything here is nefarious. It's not. I don't think the commenters are trying to hide anything. Rather, I think this is baked into the culture, a culture that says, yeah, I, like all my colleagues in this field, receive payments from industry for my collaboration, but those don't affect my judgments of the science. Now, obviously, listeners could probably guess that I believe even small payments make a difference in how we think. A corollary here is that it really worries me that so much of cardiology education beyond fellowship comes from industry. Yes, back in the day, many years ago, I was flown up to Minneapolis to do courses on pacemakers. And these were educational, but I had no doubts that industry-sponsored education is biased and affected my thinking. Now, I see major courses out there from structural, interventional, and EP, all sponsored by a company, and it bothers me. The tension, of course, is that many of the procedures that we do require intense education about the specific industry tools. So yes, we need that kind of instruction. But more recently, I can just use the example, I did not need to go on a trip with big steak dinners to learn how to do leadless pacing or conduction system pacing. Take a look at this JAMA research letter. Think about your financial conflicts. Think about how they affect your decision. I've read that some ethicists have argued that disclosure is but a small thing that probably has little effect of reducing biased thinking. And maybe that is true, but it seems like disclosure is a first step in at least recognizing sources of biased thinking. All right, next topic is AFib that occurs for the first time when patients are hospitalized. The McMaster's group, led by William McIntyre, has published a nice study in the Annals of Internal Medicine regarding first AF episodes that happened during an acute illness in the hospital. This is common. Older patients come in for a non-cardiac surgery or medical illness, and they develop an AFib episode for the first time. Usually, it's self-terminating. The question is now what to do. Is this a one-off due to the inflammation and stress of the hospital stay, or is it that the stress of the illness has exposed an underlying atrial substrate? And of course, the next question is, should these patients be formally diagnosed with AFib, and if so, started down the CHADSVASC-driven protocol of oral anticoagulants? There's not a lot of data in this space, but it's a common problem. The study from McMaster's was a matched cohort study. It's a good use of observational data. Here's what they did. They found patients from 3 academic hospitals in Ontario who had their first AF episode during a hospital admission for either a non-cardiac surgery or a medical illness, say pneumonia. For each of these 139 active arm patients, they found an age and sex-matched participant without AFib from the same hospital ward. All participants left the hospital in sinus rhythm. Then they did 2-week ECG monitors at 1 and 6 months, as well as telephone interviews. The primary outcome was AF detection. These were 71-year-old patients with a mean CHADSVASC score of 3.0. The median duration of AFib in the hospital was 16 hours. After 1 year, an exclusion of those who required cardioversion or drugs during the hospital stay, AFib was detected in 32% versus 3% in the controls. That relative risk was around 6x. My comments. This is a small study, but a very nice effort. It's a signal that says perhaps don't blow off patients who have a bit of AFib in the hospital, but also don't necessarily assume one hospital-based AFib episode requires oral anticoagulation for life, because if they detect AFib again in 1/3 of patients, that means that 2/3 they didn't detect AFib. Now, I first thought about being critical of the low level of monitoring here. I mean, 2-week monitors twice and phone calls, that's hardly extensive ECG monitoring. If these were an AF ablation study, this would not suffice. Most AF ablation studies now use loop recorders, which are, of course, always on. But on the other hand, the low level of monitoring might also be equal parts feature rather than bug. That is, the fact that they found 1 in 3 patients with recurrent AFib with this low level of monitoring is quite revealing. It makes me think, hey, that's a lot of AF recurrence. Had the patients had a loop recorder, surely they would have had caught more short-duration AFib. But since we don't know what to do with that, I'm not sure knowing that would help. Now, the one good thing that an implantable loop recorder would have done in this case would be to further clarify the baseline AF risk in 71-year-old patients who are sick enough to have a hospitalization for some reason. Now, I bet that would find it would be far higher than just 3%. The bottom line, we need more work on these first AF episodes, and this is a good start. And with the smartwatches and with more cardiac devices capable of ECG monitoring, the quest to recharacterize baseline AFib and the threshold to use oral anticoagulation is, I'd say, in the first or second inning. All right, next topic is on the same lines. Changing hypertension criteria affects the CHADSVASC score. Here's another problem with modernity. We have lowered the limit of what we call hypertension. We've lowered the limit of what we call any disease, actually, but this is specifically about hypertension. Remember that the CHADSVASC score was validated a long time ago using an older definition of hypertension. At that time, there was limited ambulatory blood pressure monitoring and higher blood pressure treatment goals. Things are different now. A group from Stanford, first author, Krishna Pundi, has published a nice research letter in JAMA Network Open showing how blood pressure goals can affect CHADSVASC scoring. The group used a big Pinnacle database, more than 310 outpatients, and they identified a first encounter. So that was like the first thing. They then used 2 hypertension definitions, the JNC8, which I call the higher one, think 140/90, and then the second one was the 2017 ACC-AHA guidelines. That's the lower blood pressure threshold, think 130/80. Their primary outcome was upscoring of the CHADSVASC, defined as receiving 1 point for hypertension for the lower 2017 ACC-AHA set point, but not for the higher one. They only considered patients who had a CHADSVASC score of 0 or 1 because, of course, it doesn't matter after CHADSVASC 2 because oral anticoagulation is already recommended. Changes around 0 would push people to a CHADSVASC 1, and that would be in the category of considering oral anticoagulation. And changes or increases around a CHADSVASC score of 1 pushes people to 2, and now they'd be in a category where oral anticoagulation is recommended. Their findings. Bottom line, lower threshold mattered. At 3 years, 83% of patients met the 2017 ACC-AHA definition, the lower one, compared with 53% with the JNC-8 hypertension definition, the higher one. At 3 years, 51% of patients with an index CHADSVASC score of 0 had a JNC-8 hypertension, the higher one, compared with 86% with the 2017 ACC-AHA hypertension goal, that's the lower one. And in patients with a CHADSVASC score of 1, 50% had JNC-8 hypertension goal, compared with 83% who met that criteria at the 2017 ACC-AHA hypertension or lower threshold. And finally, in the 113,000 patients who had a CHADSVASC score of 0 or 1 at the index encounter, 63%, two-thirds, had upscoring by 36 months. My comments. This is another good use of observational data, in that they use the data to tell us that stricter hypertension criteria is causing a bunch of upscoring of the CHADSVASC score. But we don't know if oral anticoagulation has the same benefit since it was validated in patients who had higher blood pressure many years ago. This is the same story that we're getting with short-duration AFib in the recent NOAA trial, right? Recall that the benefits of oral anticoagulation were established many years ago when it took a lot more to get AFib diagnosed. Patients had to be symptomatic, go to the doctor, had a 12-lead ECG. The NOAA studies trial found that the benefits of oral anticoagulation did not translate to people with much lower thresholds for diagnosing AFib, these shorter duration AFib episodes. So, as we reclassify more of normal life to disease states, we may need new treatment guidelines. This study doesn't say that we should change anything, but it does nicely say that the CHADSVASC of today may not be the same as the CHADSVASC of old, and that may be important for treatment decisions. So that's it for this week in cardiology. As always, I'm grateful that you listen. Remember, if you like this podcast, please take the time to make a comment. Even these 1 or 2 sentence reviews goes a long way. At least score, give us a rating. These things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.